introduction. It's a pleasure to be here. As you heard, the aspect of my career in terms of global health and humanitarian medicine is actually a relatively new addition. And it has had quite a profound impact on me. So I am so grateful to be able to speak with you about this topic. But as I was preparing for this talk, I felt like something was missing. And then I realized that it seems a bit unnatural for me to speak to a group of surgeons and potential surgeons without giving a consult as an emergency doc. So I can't make any promises, so it might come out just as a habit. As Nicola mentioned, feel free to definitely use the chat box and unmute yourself. I think we're a small enough group that we can have an informal discussion. Okay. Very briefly, I have no conflicts to disclose. In terms of my thank yous, I am very grateful to the host communities in which I've worked, including patients, local physicians, learners, and nurses. And I'm very grateful to all the conference organizers. In terms of our objectives, I know I promised this would be informal, but sometimes it's helpful to think about what, as a speaker, I was thinking about. I'm hopeful that by the end of this presentation and workshop, as a participant, you've had an opportunity to reflect on our assumptions in global health, to consider the ethics of global health electives, to examine reciprocity in a clinical context, and to consider the impact of the pandemic outside of our home country. And as you can see, these are lofty goals, but some of the previous speakers have actually touched on a few of them, so we're already ahead of the game. So let's start off. Nicole, I actually changed my mind. I will ask you to look at the chat box for me at this point. Sometimes I find that we use terms and we assume we all are talking about the exact same thing. And we actually, when it comes to defining it, a lot of our assumptions come to light. So I thought we could practice this with the word reciprocity. And I took this from the sub-theme of this workshop. If in the chat box, you could write what that means to you, you can kind of use it in an overall way or in terms of global surgery, in terms of really any context you can think of. What does reciprocity mean?
So from Dr. Horai, we have considering others as equals. From Sarah Bochin-Fuso, we have equal relationship. From Cara Feliz, we have symbiosis, gaining and receiving through collaboration. Some other answers are mutually beneficial exchange, a win-win solution.
Okay, great, thank you. So it seems some themes are coming out that relate to kind of the textbook definition, of course, as well, which is some sort of exchange for mutual benefit. That seems to be what the dictionary tells us. What I like to offer is perhaps, although not incorrect, there are many other dimensions that one word doesn't completely encompass. And particularly when we're talking about something as complex as healthcare in a global setting, maybe we're actually not completely covering the whole concept when we think about it in one word. But I completely agree with all of the definitions we talked about. Okay. I'm going to read out a quotation from an article that's sourced at the bottom. This clinic can barely function, and now it has to act as a teaching center for wealthy and privileged medical students from Canada. Now, each time I read this, another part of it stands out to me. Most recently, the part that stood out to me was has. It has to. And what I want to offer is for us to reflect a little bit on how that may be linked with the legacy of colonialism for us on this part of the world. So the question I have for all of us, and we'll cover a bit of this, is how can we reduce this risk of medical tourism on the one hand, but also not try to get to the other extreme, which at times is our white savior tendencies. And so really the question comes to, how can we create an environment that is conducive to working towards true reciprocity? Now, if we look at the literature, if we look at a lot of institutions in terms of universities, we actually note there's a lot of discussion around this in the topic of global surgery. And I'm sure many of you have pondered on this on your own and with your colleagues as well. I'm sure it's not the first time. What I came across was there are many recommendations, and these are 4 themes that I came across that I would like to share with you. One of them was to encourage students and learners to start by actually studying inequities and the social determinants of health right at home. The second was to really set some objectives and clear expectations for the beginning of one's career in global surgery or global health, but also in the confines of an elective itself. The third one is actually more, of course, related to the responsibilities of the institution, and that is to encourage and ensure there are longitudinal and bidirectional institutional relationships. So of course, that goes along with that definition exchange we talked about. And the fourth one talks about a pre-departure preparation. So maybe perhaps we can actually think about it in terms of before global health work, during, and then afterwards. So let's dig a little bit deeper in terms of before. So while we're thinking about our objectives, many of us may think about how locally we might actually be able to meet them, the global health at home type discussion. And I know Dr. Freakin touched on this, that global health does not necessarily mean international health. So the question is, if we can meet our objectives locally, whether that's within our own community or, for example, outside of our province, should we still go abroad? Why or why not? So that's one reflection that may come up. In terms of other factors that may come into the decision-making as one is going through this, I've listed a few of those. And it's really just to say that it's quite complex, right? It's beyond a pro-con list. Thinking about the level of supervision, what is the expected competency of myself as a learner? As we actually just heard, for example, medical students in many countries, including South Africa, have a very different expected competency level compared to some of our training as well. So, and we don't want to be practicing outside of our scope. Which population will I be serving? What is the power differential that exists between myself and the population I serve, the patients, but also with my colleagues that I may have there? What is my true motivation? Am I actually taking the place of local learners if I come on elective? And for those doing research, who actually is coming up with the research question? Is it the community or is it an outsider? So thankfully, we are quite lucky that all of this has been put together. And there is an article that I have sourced at the bottom by Drs. Pinto and Upshar, who are colleagues of ours in Toronto. And they've put this together as a list of 10 questions that students can consider prior to global health work. It was framed as students, but I am finding it very useful. And I would encourage you to take a look at it. I'm just going to point your attention to one of them, number 9. What do you hope to bring back to your community, and whom will you share it with? I touched on this in the beginning of my talk, but I would like to say that this is linked with reciprocity, and it is linked with what I'm able to do with you here today as well. Okay, let's get to during global health work. Before I left for my first placement with Médecins Sans Frontières, Doctors Without Borders, a colleague of mine gave some very insightful thoughts of what I should think about while I'm in this limited resource setting in terms of clinical care. So we're very fortunate that he actually ended up authoring a chapter in the textbook Oxford Handbook of Humanitarian Medicine. And a lot of what he wrote in that chapter is what he shared with me in the conversation, which I found helpful. So again, I would encourage you to look at it. Briefly, what he points out is a list of reminders. One of them is to do no harm. This is not the time to experiment. If this is something, a procedure, a surgery you would never do, even assist, for example, at home, do not do it outside home either. Quality matters. Treat patients with dignity and respect, promote patient privacy, ensure there is culturally appropriate informed consent. And of course, the local team is going to be the best resource for that. For example, in many countries, if you are if you're accepting consent from a patient who is a female, you actually do require a male relative to be present. And so knowing the reality of where you work is, of course, important. Apply standard safety and hygiene procedures, know the limits to your knowledge and surgical skills. And as you may also remark, I would like to just point out, I don't know if this is that different compared to how we should be behaving at home as well. Speaking of which, many of us in our medical training have learned the classic traditional medical ethics in terms of the pillars of beneficence, non-maleficence, justice, and autonomy. In that same paper by Drs. Pinto and Upshar, they actually offer very insightful reminders that perhaps in global health work, we need to add some foundational ethical principles. They offer humility, social justice, introspection, and solidarity. In terms of social justice, they point out that the classic justice that we think about as healthcare professionals often is very narrow and only thinks about the dimension of healthcare distribution. So of course, we know that we think outside of the walls of healthcare when we want to actually consider the health of a population. And so social justice adds to that. Another reflection that I personally had was, and they pointed out in this article as well, is the language, the moral language that's used in the classic medical ethics is of the Western philosophy. And we often are missing out when we only focus on that. And I've been thinking about how we are very individual based. I say we as in the Western philosophy that is predominant view where we are. And so naturally, when we think about the language of our ethical principles, it's very much related to the relationship between ourselves and the patient. Again, thinking about individuals. When in global health, the list I have on the right-hand side, it often reminds us that we are not working in isolation. So it actually pushes us to think about healthcare teams and to think about serving a population. So of course, there's that collective ethical framework as well. Okay, let's get out of theory. Let's go into practice. What I'm going to do for the second half of this, I'm just looking at the time, and I'm happy we have a bit more. This is the time where I'm hoping you're able to add your thoughts as I go through, but I do want to share some clinical experiences that I had on my most recent placement with Médecins Sans Frontières. And I recognize this context is very different from where many of us are working now and where many of us may never have the opportunity. But rather than looking at the differences, I thought that we could think about the similarities. I've chosen 3 scenarios where when I thought about reciprocity, this is what came to my mind. And so I offer it as perhaps helping us to expand our definition and to think about the multiple ways it can be expressed in a practical sense. I'm just going to put on the pen here. So I was in the Democratic Republic of Congo in the province of North Kivu, which is the eastern part of the country. And I was in a small territory of Rupshuru, which is bordering Uganda. So this is, I'm just putting a U because it's missing from the map. And it's about 15 kilometers to the west of Uganda. And it's very close, about 30 kilometers away from Rwanda. Now, it's neither appropriate nor am I able to summarize the social and geopolitical reality of a whole population in a few minutes. But what I hope to offer as a reminder, and I encourage you to read this if you have the chance, is just a reminder that this was the epicenter of the First and the Second Congo War. And this is a location in the world that armed conflict is still continuing. And there are now an estimated 100 armed groups in this area. And just to remind you, thinking about the context of what impact that could have on the population. And the reason why I encourage you to read about it is to, as a majority of us are Canadians, to think about our role that actually helps to perpetuate this violence continuing. Now I want to give you the reality of the surgical context as us interested in global surgery. So I was in a hospital of 220 beds, half of which are surgical beds. Of course, I mentioned that Médecins Sans Frontières had a presence there, and the role of this organization was mostly for human resources. So as you can imagine, given the security context, it was very difficult for the Ministry of Health to have enough resources for this hospital, particularly for formerly trained surgeons. So I want you to think about, when I say surgical team, there was a broad spectrum of experience and training. So the majority of surgeons who were present, meaning they were not locally, they were not locums, they were actually from the town. They were never formally trained in surgery. But of course, that does not speak to the extensive experience they've had. But again, I just want you to understand there could be a junior doctors, there could be interns, individuals never gone through a formal residency program, all on the same team. Okay, so I just want to take you back with me. I was working in the emergency department there, and we had a 12-year-old female who was brought in with her by her family from a remote village surrounding this area. She was brought in by motorcycle. They described that she had a cough for multiple months, a lot of weight loss. And then 1 week before presentation, there was a significant worsening of her difficulty breathing. One of the astute physicians also working in the emergency used the bedside ultrasound, and it became very clear there was a large pericardial effusion there. For many of us, myself included, this was a clear-cut case of impending tamponade, cardiac tamponade, and we were very quick to recommend a pericardiocentesis. For those who are more clinically inclined, there was no, and that is all of us because we're all healthcare professionals, but there was no change in her vital signs. And in terms of the echo and the clinical exam, there were no signs of clinical or radiographic tamponade at the moment. So, all of us kind of rushed this patient over into the ICU area, and we had a huddle with many of the team members to discuss who is the most competent to do this procedure. Because in any context, but particularly in a limited resource context, it is most important to ensure that's the individual doing it. So as we were discussing this, one of the local surgeons who is from the capital city and was formerly trained in surgery asked the question, who has done this procedure before? It turns out that none of the hospital-based physicians had ever done this before. One of the international surgeons assumed this meant they didn't know how, and kind of started off talking about the procedure in a very kind way. But the local physician stopped him and asked the other team members, why has this not been done before? And there was so many profound knowledge exchange that happened because of this simple question. It turns out that the reason why it hadn't been done before was quite complex. One of them was they had big concerns about the materials that we had in terms of the proper kits. Also that the monitoring we had available, we did not have ECG monitoring. So they really felt that unless this was a life or death scenario, the risks of the procedure may have actually been greater than the benefits that it could bring. They also reminded us that in terms of informed consent, for many families, they often decline it because this is very bizarre procedure and it's not acceptable for many people. So after this exchange, it became clear that although, of course, the international surgeon had a lot to offer when it comes to the procedure and how to do it, there was also a lot of the reality that we had to discuss to be able to decide for the best course of action for the patient in front of us. I bring this back to reciprocity because, again, that's where I saw it happen, where before we entered this conversation, we didn't know what exchange would happen. So there was that element of humility that came with it. The next case I'm going to bring you back to is I'm the emergency physician in this story because that's myself. We had a 3-week-old infant brought in by his family members, and they were referred from a second smaller hospital due to concerns for congenital hypertrophic pyloric stenosis. There was very classic projectile vomiting, as well as they were able to do an ultrasound which confirmed it. As we were doing rounds, again with many different team members, including the surgical team members, for many of us, myself included, this was a very clear-cut case of surgical management. And we were more so trying to figure out the logistics of how to make sure that an OR was available. I think I forgot to mention that for this hospital, we had 2 ORs available. So we kind of started off talking about the logistics of the OR, and the local, not formally trained surgeon stopped us for a moment and asked the question whether we would consider medical management just to buy us some time. And we asked him to elaborate, and he reminded us of a few studies where atropine IV had been done. By no means was this a replacement for surgery, as it is not as effective. And he did share that with us as well, but it will buy us some time. And we asked, well, what do you mean? And he said, listen, because of the pandemic, as you know, there is a huge shortage of a lot of our anesthetics in terms of the induction agents. We also had a big gap in some of our human resources. So many of the ORs, we relied on anesthetist assistants, and some did not have a lot of experience or training. So he said that our current team and our current drugs were not quite safe, and he really would appreciate our team to consider to buy time to at least get one of those factors to improve. Again, we want to make sure that the benefits currently and the whole surgical milieu is at its greatest. Again, I offer this because it really was quite humbling, but you do see this exchange of, the classic thoughts was that the international formal trained surgeon may be able to offer more, but we had a local unformally trained team member who really provided us with what was the safest for the patient. The last kind of example that I want to bring you to is more related to the link with surgery is from the trauma link. So as I mentioned, my role was there to help bolster the emergency department. There is no formally trained emergency program in that part of the country. And the thought was, of course, the preference is to have either local, meaning physicians from actual DRC or surrounding area, but international team members are relied on for specific specialties. And with emergency medicine, that seems to be where our role is. So before going in, I had some of my own preconceived notions of how I may be able to help. And one of them was to be able to help with kind of code orange mass casualty incident management plans. And as the first week or two there, it became very clear to me that the team there is so competent with mass casualty incidents because they see it every day. I mean, their surge capacity issues is every day. We talk a lot about plans. We have a lot of simulations here in our part of the world. And that is because, in a way a friend of mine put it is, we have the privilege of not living for survival day to day in the healthcare field. So we have the privilege of time. We can actually sit and plan. Whereas in many countries, there is the day-to-day. So they have so much experience. And I say they, where the context I was in, they've had so many experiences with mass casualties, unfortunately, but they haven't had a chance to reflect on some of their learning and to be able to incorporate that into their current plan. And so after a very frank discussion with the director of the hospital, that's how I was able to contribute. And that's how we were both able to kind of not think about what am I offering, what are you offering, but actually put it in the middle and work together and truly collaborate. So they appreciated some of my background and being able to help with simulations. And of course, they brought in all of the experience and learned experience with this. So in the end, again, this was for the patients that it came to. I just kind of want to put this all together so we have a bit more time to discuss, because I would love your thoughts and of course any questions you may have. Just put up some of the goals that we thought of earlier and some of my own concluding thoughts on this question of reciprocity. that I would like to offer is perhaps it is more than an exchange for mutual benefit. And what I mean by that is there is a lot of richness to this concept that we can't summarize in one word. And what we talked about is how it does involve thinking about this before, during, and after global health work, and how it's quite intimately connected with the concept of humility and mutual respect. Meaning, I'm not sure what I will be able to offer until I'm actually in that context. I can't go into a conversation thinking about my contribution. It does bring into play the team-based competencies we talked about of cooperation and solidarity. And a good reminder that a lack of formal training does not equal a lack of knowledge. Of course, it does mean different types of knowledge, and that's where mutual respect comes into place. As we know, context matters. And lastly, when we talk about medical education, surgical education, and a reflection that I've had is the purpose of education is actually a means to serve our patients in our community. But sometimes as a medical education community, we can fall into the trap of it becoming an end in itself. And I think in the world of academia, that can be quite unintentional, but sometimes we come into that. Okay, team, this is what I bring for this workshop, but I really would love to hear your thoughts and any questions you have. It can be about reciprocity, it can be about humanitarian medicine in general, global health work. Let's go for it.
Hi there. My name's Kara. Nice to meet you. I really enjoyed this talk. I'm coming from the lens of, I'm an international medical graduate. So I studied medicine in the Philippines. And I think when making the decision to go abroad for medical school, there was so much concern from friends and family about the lesser than training that I would receive there. And as a medical student, I tried really hard to organize clinical rotations that would allow me experience in both the US and Canada. And almost unanimously, the reaction was the same. Oh, you trained in the Philippines. How was the training there? And I don't have any experience with people who trained there. So what was it like? And sort of this feeling that I had a lot of imposter syndrome, but also sort of this feeling that I may not have received an equivalent medical education. And in my training there, I saw so many opportunities to learn soft skills, communication, adaptations by drawing pictures to patients, summarizing and guiding people through the hospital, hand communication, and then also just the cultural awareness and cultural adaptations that have to take place in a resource limited setting. So I think that everything you spoke about really touched on my heartstrings, but it made me really, really happy to see that there's this sort of thinking and this type of experience that's going on with a lot of medical professionals who have their experience in Canada or in the US, and then they sort of walk into a different part of the world and think first and foremost, what can I best offer here? But they end up learning that there's so many other things, and that professional respect, that mutual professional respect is really what allows for that. So I think it's really incredible that you're able to speak with all of us today and reopen our minds to that idea and the introspection. And I really appreciated the talk. So thank you.
Thank you for sharing your insights, Kara. And particularly, I think what you've also highlighted for us is some of the assumptions that we have and in terms of what a quality of education is like. And as you described some of the responses you heard when you shared where you were studying. And of course, how your experience was quite the opposite, actually, of the richness of the education you've received. So thank you for that.
Yusuf, would you like to jump in?
Sure. Yusuf, fourth year medical student. I just had a quick question. How did MSF organize your security there? I mean, did you guys work with local leaders or elders? Or?
That's a wonderful question. The approach that MSF takes for security is one where it's very difficult to eliminate risk when it comes to security in certain parts of the world. So there's a lot of risk mitigation, and in different countries that can look differently. In terms of where we were, ultimately it does involve a close conversation with the local community. And it does involve changing some of the habits. So for example, at some point during my stay there, you may have heard that the ambassador of Italy was killed in the area. And so what we had to do to be able to minimize our risk was change from ground to helicopter transportation between the capital city and where we were. So it's a bit of a complex question, but just to give you an idea of some of the ground, I guess I should say air, but the ground changes that we had to do for security reasons. So I'll leave it at that, if that's all right for now.
Thank you.
Dr. Hodai, I'll pass it on to you next.
Thanks so much, Nicola. Layli, thank you so much for an amazing presentation. It made me mindful, one of the things that you touched upon, and that is not committing beforehand in your mind what it is that you have to report until you get to where you go. And that is so different from what we generally do things. We try to sort of paint in our minds exactly what I want to do, for this thing and for the other thing, and to decide to take action and help in an area that is not known to us, knowing that I don't know exactly what I'm going to do is rather, it really puts us in a vulnerable position. And we don't want to be, put in vulnerable positions generally, particularly when we are, in the Congo. So how do you deal with that emotionally? How do you sort of reconcile yourself with the fact that you actually don't know what your role will be until you're there?
Thank you for that question. It's not an easy one, as you mentioned, because it actually is contrary to a lot of the learning we have actually, particularly, and I say we, meaning the experience that I've had throughout my training, both in undergrad, then medical school and residency. What I will say is I do think it has a lot to do with the culture of the organization that I was working with. So we have a lot of briefings and a lot of debriefings before a placement with MSF. And the classic one that we receive is up front, we're actually told the first 1/3 of your placement, meaning if you're there for 3 months, that's 1 month, only observe. It may be very tempting to come up with a bunch of solutions because it's so easy to see sometimes problems, but please take the time to observe. And I found that advice very, very helpful, actually. It can be, not to say that I always followed it. And I think that also is a nature of some of my emergency training, where we often want to think and act quickly. But I will say that was quite helpful for me to be able to practice that faculty of observation. And the other aspect of it, I think, really does have to do with, it's very difficult, but trying to suppress my own ego. And I say that because, again, so much of our culture in academia, but also academic medicine, is to kind of bring ourselves up. We have awards for each other. It's a lot about the individual. And sometimes, depending on where your placement is, and I think Kara actually pointed towards some of the cultural differences in many other countries. But what I loved about many countries I've worked in outside of Canada is the sense of the collective is a lot stronger than here. Meaning that when there's a really good outcome in the OR for a patient, it actually is not like patting on each other on the back, because it isn't the one person who did it. There's often a recognition that it was the whole team. And culturally, it often is, of course, sometimes a higher power that also helped. But then the opposite is true too. I'm digressing a little bit from your original question, but if we don't actually think about it as an individual, then if there's a medical error done, we also don't bring down the one healthcare professional. We kind of bring it in as a whole team. So I guess all that to say, I think that that in itself has really taught me. I have been on 3 different placements in this context, so I think with experience it happens as well. It definitely isn't easy to not be tempted to come up with solutions before you actually can understand a bit of the context.
Anissa, I'll pass it on to you.
Thank you. Thanks, Dr. Sanaee. Really wonderful talk. I guess I wanted to ask about some of the clinical skills that you felt, during your time at MSF. What were you trained in, and what do you think was missing from your training, particularly to, like help with patients in different parts of the world? Thank you.
Also, very good question. Thank you, team. So what I would say is, I didn't have a chance to describe this in its fullness, but as you can imagine, with the organization that I chose to work with MSF, there's a broad range of types of projects, and there is also a broad range of skills that one may need. When it comes to surgery in itself, as you have heard from multiple individuals and you know yourselves, globally, there's a large need for both competent surgeons in terms of the actual skills and also the competency to be able to teach surgery. So that, of course, extends into humanitarian work as well. So many surgeons are hired for MSF to actually really do the clinical work, just because there's a large gap in those who are formally trained. So I'm kind of speaking more so for my surgical colleagues. And then in terms of myself, the role of emergency physicians is a little bit different. The thought is that the local physicians are so much more competent in terms of understanding their reality. For example, the most common presentations we would see was malaria, cholera, respiratory illnesses. The most common cause of acute peritonitis there is typhoid fever, not appendicitis, in the pediatrics world. There's so much that has to do with the actual context that you need the local physicians. Same with procedures. Of course, I may have received quite a good training in terms of a multitude of procedures, but when there's no central line kit available and no way to put a central line in or monitor, that is useless where I am. We had no ventilators, so we would not be intubating anybody. So again, a lot of what I found most helpful was, and Cara pointed to this, and I'm going to recommend instead of soft skills, we can actually say maybe most of the strongest skills that we can have as physicians is being able to MacGyver in terms of, with the knowledge we have, be able to apply it in any context. And that's much harder because it involves experience, and often the first time we do something, we may not know how we can translate the skills that we do have to an entirely new context.
Kara, I'll pass it back to you.
Thank you. I just have one more question, and it's in the context of anyone who, as part of their residency training, is looking to do global health electives. Can you sort of summarize some of your best strategies or offer your wisdom with building rapport with both colleagues and patients when there's a language barrier? Thanks.
Thank you for that question. I think it's one that's on many of our minds in global health work. And many of us who train in larger centers do have experience having patients who speak different languages as well. And I think this is a skill that can translate quite nicely, pun intended a little bit. So what I will say is, from my experience, what really helped was to actually do your best to learn even a few words to be able to communicate with the patients. Not to suggest that that means you can speak the language, but to build that rapport. So I was both in Chad and DRC. The language I spoke with my colleagues was French, and I do speak French. That was helpful. But in both places, the patients did not speak French most of the time. On this last placement, Swahili is what is spoken in that part of the Congo. And I was able to thankfully learn a few phrases to introduce myself, to be able to ask how the patient is doing, a few in terms of the plan. And it was, I mean, I can't speak to the experience the patients had, but my understanding is that it helped build that human connection a bit more. And of course, I would still rely on the interpretation of my colleagues, just to, of course, make sure that it was safe in terms of the history and also for informed consent. So that's one thought that I had to offer. I'm very curious if others have other things to offer, whether it's from your learning here in Canada, or I'm not sure where everyone is coming from, actually. That's a question I was going to ask. But of course, that was one thought that I had.
Albors, you're welcome to jump in.
I'm not going to answer that question specifically. I don't know if I can follow up with another question of mine. Would that be okay, Dr. Sanaee? Yeah, okay. So
I thought Nicola was in charge, but that sounds good to me.
I think I'm going to talk on behalf of a lot of medical trainees who are literally at the beginning of their training, at their first or second, or even in their clerkship, and they are very excited to join and contribute to the experiences that you had. And they are obviously enthusiastic about the global surgery because they're here. I was wondering what advice you have for someone who is in who's a medical student, to at least build some of those capacities, that when at least they're in residency or as a staff, they can contribute to these quote unquote missions or these experiences like abroad.
Thank you for your question. I'm happy to offer thoughts, but I also would love to hear others' thoughts, because it's a difficult and complex question, which makes it a good one, of course. You know, some of my own experiences that I had while I was in medical school and residency really profoundly shaped my further desire to go into this field, whether they were positive or negative. And I think I can share with this group that, you know, some of the placements that I had as a learner, while I was there, I realized this is not where I should be. As a learner, this is not appropriate. And you don't want to be in the middle of a placement when you realize that. So in terms of the preparation piece that I was discussing about earlier, I do wonder if perhaps sometimes the answer may not actually be what we think, in terms of, to be able to go into this field, I need to physically be in a different area. So that's one thing I have to offer. In terms of what we can do, what you're doing today, I think, is quite profound. And that is trying to learn more about the reality outside of where your training is. And I do think that particularly when you're going to be in residency, it's so important to be able to practice medicine outside of where you've trained. Because if you think about it, it gives you, we're so privileged being physicians and surgeons because we actually learn so much about a community from that lens. And so I do think that not only in terms of the medical education that you gain, but of course the impact it has on you as a whole being, it's quite profound. So I don't know if that's concrete enough, but to summarize my thoughts, I think it can be twofold. One of them is the practical electives, but of course the other one has to do with thinking about the realities outside of where you're training.
Thank you for that.
Are there any last minute questions for Dr. Sanaee before we end the session?
I've just put up my email there in case anybody has any further questions or just want to say hi, you're welcome to. I know that we didn't get to cover quite a bit, so I thought I'd leave it up there.
All right, well, in that case, Dr. Sanaee, I'd like to thank you so much on behalf of the Global Surgery team for the wonderful presentation and for the very insightful discussion.